So now I have the privilege of introducing our second speaker, Dr. Anku Mehta, who will be providing her perspective of the educator's role in addressing time and range in the clinic. And Dr. Mehta joined West Hertfordshire Hospital in 2018, where she is a consultant obstetrician and gynecologist with a special interest in obstetric medicine. She is the lead for endocrine disorders in pregnancy and runs joint antenatal clinics with endocrine consultants for women with diabetes, thyroid disorders, and other endocrine disorders in pregnancy. She also runs obstetric medicine clinics for women with medical disorders in pregnancy. She provides preconceptional advice to women with medical disorders, and she is a member of the National Expert Reference Group for Gestational Diabetes in the UK. And she has a keen interest in quality improvement and has introduced remote blood pressure and glucose monitoring in pregnant women in her trust. And she's currently leading on a national quality improvement for improving inpatient management of pregnant women with type 1 diabetes. And she's the principal investigator for the PARIT-2 trial, and also, which is actually a multi-center randomized controlled trial of revealed versus concealed repeat placental growth factor based testing in women presenting with suspected preeclampsia. So wow, that's a lot. Very impressive. We're very excited to have Dr. Mehta. I'm going to go ahead and turn it over to her.
Thank you so much, Dana, and thank you, Dr. Brown, for an excellent presentation. And thank you, ADA, for giving me this opportunity. So I'll essentially be talking from an obstetrician's perspective. I know Dr. Brown gave you a brilliant endocrine's perspective from this point. So I will be talking about our national pregnancy and diabetes audit data from the UK. I'll be talking about the evidence which we have used for CGM in pregnancy, particularly the lessons learned from the CONCEPTT trial, the national implementation of CGM in pregnancy in the UK, and the impact on real world outcomes. So this was a national audit which was started in 2013 in the UK, in which we look at all women with any type of pre-existing diabetes across England and Wales, which started in 2013. This is the latest data of nearly 10,000 women with type 1 and type 2 diabetes between 2019 and 2020. And this is the first time when type 2 has sort of overtaken type 1. We now have more women with type 2 diabetes in the UK than type 1. And if we compare it to our data from 2003, there's been a 100% increase in women with type 2 diabetes, and the number of women with type 1 diabetes is also on the increase, and gestational diabetes as well is increasing far more, which we are all aware. The first question that this audit wants to ask is that were women adequately prepared for pregnancy? And we can see, unfortunately, that since we had this audit in 2014 to now, unfortunately, we haven't seen an improvement, and only 1 in 8 women entered pregnancy well prepared. And why does that really matter? Because if these women don't enter pregnancy well prepared, they've got a high risk of having congenital anomalies, stillbirths, neonatal deaths, and that could be higher than 10%. Whereas if they enter pregnancy well planned, their risks of serious complications fall closer to that of women without diabetes. So if you can see the HbA1c, ideally according to the NICE guidance in the UK, we don't want women to be pregnant if they've got an HbA1c of 86 or over. But unfortunately, time and again, we see women who've had unplanned pregnancies and they end up with more complications. The higher the HbA1c, the higher the chances of anomalies, perinatal deaths. And we looked at this forest chart, which you can see, where we looked at what were the factors which were affected most at higher HbA1c levels. Those were younger women, higher BMIs, deprivation, and a longer standing type 1 diabetes. So essentially, we wanted to prioritize these women to have continuous glucose monitoring. And then if we compare our outcomes from 2014 to now, are we getting better? Unfortunately not. We still have a lot of preterm babies, large babies, and we're not really improving, but we are sort of, the complications are increasing. Women are becoming more complex. They have more comorbidities. They are older, they're bigger and more complex. How can we minimize these complications? It is well aware that women who have an HbA1c of 48 or more, which is 6.5%, as is used in the US, are in the third trimester, they have a higher rate of preterm, large babies, as well as neonatal admission. So having a good control would have better outcomes. We also looked at adjusting the data for diabetes type, duration, ethnicity, deprivation, and BMI across the country, because we had data from the whole of England and Wales. And unfortunately, we found that there was very minimal variation between the clinics. So clearly, there was something different that we all needed to do if we wanted a different outcome. And that is when NICE guideline with an update of CGM came in December 2020. The question that was there in the evidence review was like, what is the most effective method of glucose monitoring to improve maternal and infant outcomes? So we're looking at both good outcomes as well as cost-effective outcomes in the NHS. So we looked at continuous glucose monitoring, flash glucose monitoring, which is also known as intermittent scanned CGM, and capillary blood glucose, which is self-monitoring of finger sticks, SMBG. So this is the evidence. I'm not going to go in too much detail. Overall, we looked at 2 RCTs and 1 retrospective cohort study, of which the CONCEPTT trial was the most powerful study. CONCEPTT trial was a multi-center international randomized controlled trial, which looked at women who had real-time CGM versus women who used fingerstick alone in managing their type 1 diabetes. So if you can see, the primary outcome that they were looking was the change in HbA1c. There was a small but a significant difference in these women from baseline to 34 weeks. Women with CGM had a lower HbA1c. The percentage of CGM time in range, which is 3.5 to 7.8, which is an internationally accepted standard, as Dr. Prong pointed out. CGM mums spend an extra 100 minutes in glucose target range. And I just, from an obstetrician's point of view, I would just stress on that a bit more, saying that it doesn't sound a lot more. It says just 100 minutes, but I think if we've been looking after mums with diabetes for a while now, and actually they are very, very complex pregnancies. They are long-standing diseases. They want some sense of normalcy, you know, even their childhood, you know, they wouldn't, it's not as easy as going to a birthday party and having the cake as and when you want. So they've come from, they will also have mental health issues, anxiety. They sometimes tend to blame themselves as well. When we tell them, you know, there's a lot of information overload as well. We tell them that, you know, you've got type 1 diabetes, these are the risks to your baby. And they sometimes carry that guilt as well. So I think it's very, very important that we form a rapport with the woman and understand where they're coming from. And their targets are a lot tighter when they're pregnant than when they are not pregnant. And often they are the most motivated when they're pregnant. And it's not unusual to see someone who enters pregnancy quite poorly and then literally turns around because she's so motivated. So it is all very good that we have so much data, we've got so much information and education to empower them, but it's really, really important that we establish that rapport, that whatever they're doing is good and every little helps. So I think that's really, really important. And when we use real time, if you look at the outcomes, you can see that the large for gestation age babies, hypoglycemia, neonatal admissions, were all less in women who used CGM. And if you look at the numbers needed to treat, it is quite impressive that you just need to treat 6 women to have 1 less large for gestation age baby and 1 neonatal admission. So that's a good economic as well as a good outcome. This is observational cohort study, which was from Sweden, which was also looked at, but given that it was an observational study. It was not a very powerful study, so we could not really base our evidence significantly off it. But you can see they compared women who had real-time CGM versus intermittently scanned CGM, and there wasn't a whole lot of difference in their time in range. They're pretty similar. There wasn't a lot of difference between 10 and 30 weeks anyways. But what was found was that women who used intermittent scanned CGM, they had a higher time below range across pregnancy, and hence those women would need more SMBG, would need more finger prick testing as well compared to a real-time CGM, where we don't recommend them doing checking their sugars. And I think that's slightly different to what the practice in US is. I'm just going to skip this. So eventually NICE clinical committee, they looked at these evidence and they looked at the quality of life, neonatal stay, postnatal ward stay, and overall it was decided that it is actually quite cost effective to introduce a real-time CGM, because it offsets the cost of staying in a neonatal intensive care unit, and the postnatal ward was offsetted by the cost of the equipment. And from December 2020, across the NHS, all women with type 1 diabetes are offered real-time CGM to improve neonatal outcomes. We enter our data to the national data set as always, and we want to ensure a fair and equitable access, because these are the women who need it the most. And there has been a lot of support, training for healthcare professionals as well as patients, education for optimal use, because it's all very good that we have so much data out there, but what we do with the data is far more important than actually having the data. Again, this is looking at the clinic to clinic variations, so not huge variations, so clearly new interventions were needed, and that's when the NICE guidance came up. So we offer it to all mums with type 1, and we also offer it to mums who are on insulin therapy but do not have type 1 but have a severe hypoglycemia or have unstable blood glucose levels, or have eating disorders, mental health issues, or are needle phobic. Whoever you feel you can apply the funding for. Dr. Brown has already taken us through this, so I'm not going to spend a lot of time on this slide, but I'll just, especially from the obstetricians in the audience who don't see this on a very daily basis, and I believe the number of women with diabetes is on the rise, and I think everybody should be aware your time in range is 3.5 to 7.8 or 63 to 140 milligram per deciliter. You want to achieve more than 70%, and just to be aware that 1% is 15 minutes. So this was the data from the CONCEPTT trial, and CGM, in CGM mums whose babies had large for gestation babies and neonatal hypoglycemia versus those mums with CGM who did not have these two adverse outcomes, the time in range difference was as low as 5%. You can see from the absolute difference here. So actually, just that extra 75 minutes a day of having blood glucose between 3.5 to 7.8, actually, it will improve outcomes, and it will reduce your chances of having a large baby and the other issues that come along with it, and neonatal hypoglycemia, admission to the neonatal intensive care unit. So do we still need to measure HbA1c? Definitely. We very much use it as a predictor of pregnancy outcome at the beginning as well as in the third trimester, and it's a very good assessor of obstetric and neonatal risk. Understanding that the value can be marred or skewed by anemia, the hemodilution in pregnancy, and other hematological disorders. For CGM, the best predictors were time in range, time above range, mean glucose, which we look at, and that, like Dr. Brown showed in her slides, it's very much for the woman to sort of guide her diet, her insulin therapy on a day-to-day basis, be mindful of what she's doing and looking at her patterns and working on her data. And time in range can also predict preterm, large for gestation and neonatal hypoglycemia and neonatal admissions from 12 weeks onwards. So we are quite aware that when we say we should enter pregnancy well in these women, it's sort of, you've sort of set the ballpark very early on in pregnancy, and we want them to be very well controlled right from the first trimester onwards to have a good outcome. So CGM is a different way of thinking about diet and insulin. When women look at their patterns, they are able to then recognize, I won't go in depth because Dr. Brown has already taken us through it, but the pattern recognition, understanding simple things like, what did I eat, and can I do something different? Do I need to, if I exercise this much, do my sugars come down? I probably need to give my insulin, earlier than I did. So all those peaks and troughs, they would reflect on that. This is just from the concept trial, the UK participants, if you look at the diet that they were eating, so 50% of their diet was non-recommended sources. So if they are looking at their data and they're looking at their sugars and what they're eating, patients are a bit more mindful, and then they can act on that data. This is just a little bit of top tips, which are there in the Diabetes UK website as well. Timing of meantime bolus, earlier in pregnancy, at least 20 minutes, and later on in pregnancy, about 45 minutes later. Attention to the quality of meals, like I said, and these women would then use the alarm. So what is different than checking your sugars, if they were checking a finger prick, is that they have to actually check. So if they don't check, they don't know. So with the real time, it actually alarms you, it shows you the trends, and you can avoid hypos, avoid your sugars going too high, and proactively, without getting scared, increase your insulin. And again, the aim would be to get the trajectory time in range as soon as possible in pregnancy to get it on target. This is our latest CGM feedback. The woman in the picture, she was our first patient with real-time CGM. And actually the women love it. And they say it's life-changing. These are some of the best floods that I've ever had. One less stress and preventing serious nocturnal hypos in a busy job. It alerts to your phone so that they don't have to pay attention. And actually it forces you to pay attention and to act on the data. So take-home messages are use of real-time CGM, as shown from the concept trial, does improve maternal glucose levels and improves neonatal outcomes. Currently, we are offering that to all women with type 1 diabetes in the UK and other women who are insulin dependent as and when needed. And we use CGM rather than HbA1c and SMBG to guide the diet and insulin therapy. And I would say that 70% time in range, yes, that's what we want, but every 5% improves the outcome. And in second trimester, it just helps women in intensifying because their requirements go up because of the insulin resistance and the increased need. And women with type 2 diabetes, they are quite complex, and we know now with the data that we have, they have actually got a higher rate of stillbirth, looking at the last 2 years data. So we should be considering them. Obviously, we don't have that much data and evidence to support that, but it does help. Thank you.